Thank you so much for this kind invitation. I will talk about next frontiers in therapeutic endoscopic ultrasound. This is my financial disclosure. So, U.S. indication has make a very important evolution, not just because initially we use it for evaluation and diagnosis of many diseases that were limited by uh, normal endoscopic vision, and it makes possible to evaluate everything that was around the mucosa or the gastric or gastrointestinal lumen, making possible a better evaluation of biliopancreatic tumors or biliopancreatic disease, to epithelial lesions, gastrointestinal malignant lesions, to classify it in a proper way. Also to evaluate undeterminate jaundice, mediastinal tumors. But nowadays, there is a big role in therapeutic applications. So in terms of therapeutic, we have five kind of therapeutic developed by US. One has been drainage. We can drain pseudocyst and also nowadays video pancreatic ducts, for example, or collections. We can make injection therapy through the needles, through the linear US as neurolysis. That was the first therapeutic uh, endoscopic ultrasound treatment that was performed. Also, injection of alcohol or oncotherapy injection inside cystic lesion and tumors. We have also ablation therapies through the needles as radiofrequency and microwave technology. Nowadays, we can make a vascular therapy. It means make a treatment arterial or venous treatment, and also we can have an access. What it means we can get use the endoscopic ultrasound technology and make a bridge or an access to a certain areas where was difficult to have a normal access through the gastrointestinal wall. So the rationale is for therapeutic US is easy and safe, the access superior to upper gastric uh, GI, possibility of US guided treatment, as already I mentioned it, no scars, mortality decreased, immediate recovery, less hospital stay, and its cost effectiveness. So in general terms, as you can see in this cartoon or design, at least we can show the ways that we can have an access even in the right hepatic lobe in certain cases, but we can do a lot of different access by different ways, by different windows. It will depend on the patients and also of the position of the lesions. So for video pancreatic drainage, we have two techniques. One is the rendezvous technique, and the second is the transmural technique. Both of them we need to pass through the gastric wall. In one of them, we try to take to make a rendezvous technique. It means deploy a guide wire and retake it for the natural way to make a drainage, for example, for biliopancreatic drainage. In the other way, when it is not feasible, we can make a transmural technique. So this is an example of a patient with a very difficult biliary tract. So you can see it was almost impossible to see the ampulla here. And this patient have a pancreatic tumor. So we need to make a biliary drainage through rendezvous technique you can see. And then we take the duodenoscope and then we pass and put a metallic stent. So this case is an example of antro choledocho gastric drainage through the antrum, for example. So this patient with pancreatic tumor, difficult to have a good access. So we needed to make a drainage and it was possible through this way. So this is an example of US guided hepatocgastric gastrostomy. You can see here I'm in the left hepatic, you know, lobe. So we pass our needle, we make an injection, we make a cholangiogram, and then we push a guide wire, and then we make the fistula. And then once we get the fistula, we deploy the metallic stent, as you can see here, having a good drainage. In this case, a patient with cholangiocarcinoma that was not possible to make a drainage by ERCP, standard ERCP. So there is another examples, more risky examples. So this was a patient with a very difficult tumor. It was a duodenal obstruction. Just to understand that it's very important always to have the drainage of the duodenal part, because if not, the patient will not be solved. So we decided to make a drainage of the duodenal part first. And then the only window that I had at that moment was in the entrance. You can see here the portus splenic uh, vein, and then you can see here the main biliary duct. You can see here. So I pass it. We see the image in 2D, so it was really difficult to see if I was passing or trespassing the the portal vein. But in this case, we didn't have any difficulty. However, I decided to make the fistula using a balloon because the cystosome, it was too risky. It was too near to the portal vein. I didn't want to make a complication because of the electrocautery. You can see here I am deploying. And then the reconstruction, you can see here the stent, and you can see here the portal vein after the CT. So the patient was sent to therapy in spite of, of uh, of everything. The survival and the quality of life was much better. So nowadays we have lamps, luminal apostolital metallic stent, and we can use it for drainage. You see here a lot of cases, that we can have been using this. It's easier, faster, and much better results in terms of long term of patency in comparison to other techniques. So here we have another case. This is a very interesting case. So this is an antegrade drainage. This is a cholangiocarcinoma. You can see here it was not possible because of anatomic alteration. So to have an access. So in this case, we decided to make a antegrade drainage. You can see here. So I am using a special stent, Bona stent for US. Is more flexible and less how to say uh, less French. So once the fistula is created, you need to go to you see, the natural lumen. This is the ampulla you see here. So I always put contrast just to see where I am, or you can be have a direction just with the air in the duodenal part. So then we start to open. You can see here. So you can make a reposition of the stem. So you can see here, for example, we make a very good drainage. We deliver the stent, and in this case, we make a good treatment. This patient was sent home and received uh, oncological therapy. So in some cases, we can use also lamps for intrahepatic biliary drainage, like this case, for example. And in other case, you need to have hybrid interventions. It means difficult cases where you need to use different ways to make a drainage of the biliary tract. As in this case, for example, we put it to metallic stent. It was advanced. It was an advanced cholangiocarcinoma. So just palliative treatment. Excuse me. And then if you can see after both metallic stent, we saw this, drainage. This collection is still here in one part of the tract. So we decided to put lamps trans gastric, and you can see a good drainage here. So what is the best approach? To be honest, this very good meta-analysis and review, systematic review, showed that there is no difference in terms of adverse events when you are doing hepaticogastrostomy or choleleucoduodenostomy. So in real situation or real clinical practice, it will depend of in the quality of the window that you can have to do this drainage. So we can have a lot of adverse events. However, most of them can be managed by uh, endoscopy. You can see here one example. For example, this is a patient that I had. I was trying to make a bit of drainage, but there was a stent migration. You can see the intestinal lumen, and here the stent. This is the bill is going there outside, and this is the stent still, you know, in the inside the biliary tract. So what I did it is to pass through the tumor, through the papilla with the cystostome to create a fistula through the tumor, and then to recover the stent and treat, make a reposition of the stent, as you can see here with a pediatric um, rat tooth uh, forceps, and then we can manage with another stent like a biliary leak, and you can, treat this adverse event by endoscopy. So, what about US guided gallbladder drainage? Well, we have complete indication in cases of cholecystitis with patients with high risk surgical patients or patients with complete biliary tract obstruction due to pancreatic cancer or another malignancy, also as a palliative treatment for jaundice obstruction due to pancreatic tumors with failing ERCP and unable to use biliary drainage and with cystic duct permeability. So the outcomes reveals technical success in 100%, functional success in 91%, adverse events in 16%, and stent dysfunction in 8.3% of the cases. So this is a very good case that was treated initially, by ERCP and metallic stent because of pancreatic tumor. And this patient, developed cholecystitis, and there is an increased risk of cholecystitis that we demonstrated in a publication in GI endoscopy a few years ago about the obstruction of the main cystic duct. You see, so in those cases, this patient make a because of the bacteria, they make a infection and then develop the cholecystitis with a high risk in 40% of cases. So prophylactic drainage is already demonstrated to have a very good results to avoid complication. So I want to talk about these two papers from my good friend and colleague Dr. Teo from Hong Kong, where they compared initially, the results of US US gallbladder drainage versus laparoscopy. So showed similar results in the short term at the first year. So in terms of collection, so we can see we can use lamps or other stent to make drainage like this one. In this case, was a patient with different comorbidities, and this patient have 89 years old with complicated, gallbladder, cholecystitis, and so the surgical team didn't want to make the treatment, so it was sent to us, and we make the solution. So we can also drainage the pancreatic duct. The indications is pancreatic duct who needs decompression due to stenosis or stones, pancreatic duct stenosis secondary to surgery, for example, Whipple, endoscopic ampulectomy with failure to cannulation of the pancreatic duct or disruption of the pancreatic duct. The technical successful is in around 81 to 92%, is operator dependent, and also, it will depend also on the anatomical characteristic, and the adverse events are in around 9 to 14%, and are bleeding, perforation, and pancreatitis. So this is one of our cases that we have here. I want to show you a little bit the technique. Don't be, scared about, this contrast, it's hydrosoluble contrast, so no worries about that. The most important was to have a good duration. Sometimes we need to retake the pancreatic duct you see here. So I take the good position and then I make a double drainage, one inside the the intestinal wall and the second one in the gastric you see here. So with a double pigtail, and then the first fistula that I did it, I closed with Ovesco, you see. So in that way, you can make a treatment, and these patients, goes well after, and you can stay like 6 months or even 1 year. So it depends, and you can remove and retake it. So in our institution, what we do right now is retake the patient and make a pancreatoscopy to see if the stenosis was completely removed. For example, this is another case recently. Also, this was after um, partial pancreatectomy and stenosis you see here. It was very difficult to pass. So I used the cystostom, you can see here, and then I cut a little bit with the cystostom. We are almost ready to make a publication about the use of cystostom in this kind of fibrotic tissue. It's not a contraindication, it's not a big risk because we are doing the same that we are doing in the esophagus, the septoptomy, using the cystostom, and then you can make a reposition of the guide wire, for example, and then you can make a double access, you see here, and then deploy the stand, make a balloon dilation and working directly, and then make a solution for this patient. So I will talk about US guided cholangioscopy and pancreatoscopy. This is a new proposal technique that we are doing here. So this was a very nice case, a 16 years old woman that had a complication of gallbladder surgery that have a uh, complete section of the biliary tract you can see here. So there was not pass. When we received this patient, we initially needed to treat the cholangitis because of the lack of drainage. So we make a drainage in the right biliary intrahepatic and the left one you can see here. So what we did it was a very difficult case, you see. I tried to see where was the anastomosis that was completely closed. Uh, so you can see I put a lot of pressure just to see it. It was not possible. You can see here I removed the first stent, and then I use a cholangioscopy, to see where we are. I am looking here the right biliary, the right intrahepatic biliary tract. You see here the stent that I put it. So then I tried to looking for where was my anastomosis. Very difficult. You can see here there was not anastomosis. There was, I know it was by this way, but I didn't see it. So I passed another cholangioscope, and then after try, we arrive and we achieve to see exactly where was the anastomosis. Very tiny anastomosis you see here. So, and then what we did is to make a balloon dilation and to put a plastic stent, and then, we avoid a sur third surgery in this patient. So it is another alternative that you can use it. This is another case. I like to show it different kind of cases that we have. In this case, we have a very difficult, case of stenosis over a liver cirrhotic patient. So the patient was in cholangitis. We need to try to make the drainage. It was not possible to find. You see here, uh, the tract because of cholangiocarcinoma. It was almost impossible. So in this case, we decided just to less biliary drainage, as a palliative treatment uh, through hepaticogastrostomy. So we combine the cholangioscope and then the plastic and metallic stem, some kind of cases like this one, for example. So this is another case. It was a patient with that came to our unit, we initially we performed a drainage, a gastrostomy, and then we pass a cholangoscope to see where was the stenosis. Then we can make a balloon dilation of the track. It's easier. Pass the cholangoscope, and then we can make a balloon dilation until 10 millimeters. And don't be afraid about the 10 millimeter of the anastomosis. It will broke all the fibrotic tissue. And if you have a leak, you can put the stent. So you see here. So we put it. We didn't make any other. Uh, Let me see. I think we put it. Yeah, we put it biodegradable metallic stent. So in those cases, when with refractory treatment, so this patient had like a treat balloon dilations, and one of the big advantages is that everything is inside in the stomach. So no electrolytic or loss of fluids in those patients, and no damage in the skin. So cases, very several cases or difficult cases like this one, so we can have a direct access through cholangioscopy you see here. So this is another proposal. We are almost making the first publication of this. So you can see here what we are looking and what we need to do as a treatment. For example, lithotripsy, we need to do it, and then antigrade balloon drainage of the stones once it is treated. So we have other different cases like this one, for example, where we perform, this is a patient with pancreatic disease. So it was a pancreatic tumor due to cystic lesion. So in this case, we need to drain the cystic lesion, and also we need to drain, because it was palliative, we need to drain the biliary tract. You can see here the gallbladder, the biliary tract, and then also the main pancreatic duct. The three treated by lamps, and also we needed to clean up. You can pass a cholangoscope through the pancreas. It was an IPMN, with malignancy and chronic pancreatitis. So in this case, we had the chance to make a drainage, and after we delivered the patient feels much better. We removed the stones, we destroyed the stones, and we make also a transpapillary drainage combining techniques. This is another interesting case. You see the dilation. In this case, for example, we used another lamps. This was patient, a 91 years old woman with a lot of pain because of cystadenocarcinoma. So what we needed to do in this case is, what we tried to do in this case was to make a drainage, and a natural, it's like the natural history of the disease. So the cystadenocarcinoma killed the patient because he needs to go up and start to destroy the tissues around them. So what we did is a lamb's drainage initially to the stomach to decrease the compression of the main pancreatic duct and the pancreas, and then we make a drainage, in the in antegrade weight by you know by endoscopy. So different other cases like this one, for example, this 59 years old that had a complication after surgery. So we make a US guided cholangioscopy. You can see here in the US, a direct cholangioscopy pass. Is that one that you are looking here? So you see the contrast is not enough, because we can not say what is going on inside. However, when we make an exploration of biliary tract, we saw that the patient had in the side of the anastomosis, there was a complete burning and stenosis because of, of cautery. So in these cases, it was not possible to make retake the biliary tract and then anastomosis. So the must it was much better to make a drainage, and that is what we did, because there was a bilioma also. So we make a drainage with a plastic stent, and then we wait for the drainage of the of the bilioma, and then the patient was sent into surgery 3 months after. So I would talk a little bit about US guided ablation therapy. So a few data available: palliative treatment for pancreatic cancer as an option is a safe and feasible for benign masses, neuroendocrine and unresectable pancreatic masses. Other indications are celiac ganglion radiofrequency ablation for palliation of pain in pancreatic cancer. So what about radiofrequency in pancreas adenocarcinoma versus neuroendocrine tumors in uh, adenocarcinoma? The technique is a little bit more different. So we use 50 watts. In neuroendocrine tumors, we use 20 to 25 watts because of the risk of pancreatitis. The response until now is 100% in terms of as, technical success. And in the 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 study that was published by us in gastrointestinal endoscopy showed also a reduction of tumor that from 39.5 to 26 millimeters in 5 of 11 patients with more than 50% of reduction. In neuroendocrine tumors, they have a curative treatment for sure. So the adverse events are abdominal pain really low, and no pancreatitis, at least in our series. In global, in neuroendocrine tumors, they can have 20% of adverse events, similar to pancreatic adenocarcinoma. However, they can have more moderate pancreatitis and more pain compared to pancreatic adenocarcinoma. The survival reporter is in between 12 to 24 months. Uh, However, for patients with metastasis in adenocarcinoma, is not indicated. So, so I will show a little bit what we can do right now, not just one treatment. We can make all the treatment in a single step. I'm sorry. Um, it means so in this case with invasion. So this is a palliative treatment. In this case, I decided to make with the patients to make radiofrequencies. You can see we are using EUSRA here. So you can see I start to do it from the distal part to the proximal part until it becomes wide tissue. So at 50 watts, you can see here. So you see, start to make white. It means it is destroying the tumor for sure, because the peak of the heatness is very high, and after that we can once we create the whole tumor, I go to the whole areas of the tumor becoming white, uh, the tissue that it was hypoechogenic to become hyperechogenic, and then I make a drainage. In this case, for example, you see, I use after the radiofrequency treatment, I prefer to do drainage with lamps because I needed to make a second session in case of, this is one of the advantage to decide why to put first US guided drainage than ERCP. So you can come back and make other radiofrequency. So in terms of microwave ablation, there are some cases in series. So we published it many years ago, some cases. Right now, we will start a second study uh, for other indications. You can see here, very nice. This is a patient that had a pancreatic mass because of neuroendocrine tumor with a renal failure that was contraindicated to any kind of treatment. It was just a palliative treatment. So we made a microwave ablation. The difference is the heatness is more controlled. You take more time, and this is the control after 3 months. The patient, recovered completely, and we destroy the tumor. That's why in neuroendocrine tumors it goes very well. I will talk about a little bit about US guided vascular therapy. So we are using more and more for treatment of gastric varices. You can see here, this is a case of in the technique that was published by us in 2019, digestive endoscopy. So we can use, you can see uh, the feeder vessels to treat the gastric varices. You can see the disappearance of the gastric varices practically immediately after the treatment. So the patient recovering in less than 24 hours, and you can send home once the patient is doing well under beta blockers. So in case of massive bleeding as this one, where we cannot see anything, you see here, you can see here the quantity of blood of this patient. You see here, this is blood in the fundus. So in those cases, it's very interesting when the patient is with under shock, hypovolemic shock. So we wait to fluid resuscitation. The patient was intubated, so we were waiting, and then when we will start to see the flow, we go inside the the feeder vessel, to be honest, and then we see with the contrast. That's why variceolography is very important. You see that this is the side of the rupture of the varices, and this was the feeder vessel. So we are in the right place. This is one of the advantage to make a US guided treatment over a standard technique with endoscopy. The other thing is that sometimes it's difficult to see the uh, isolated gastric varices. In this case, you see here isolated gastric varices secondary to a thrombosis of the splenic vessels, you can see here. So in this case, I defined it that this was the feeder vessel. You can see here, here is going there, and this is more deeper. So I tried to go in this area, and then using a 20 gauge needle, in this case, I just use this because of the diameter of the vessel. So I make a contrast to see, you see if there was any flush, any shunt, for example. And in this case, I didn't saw any shunt, any risk. So I decided just to put the glue directly, having a very good results in this patient. But this is not the final treatment. This patient need to have a surgery because that's the thrombosis was secondary to a surgery. So the modified technique we use to go directly to the feeder vessel, sometimes we can see more than one feeder vessel. And the difference from the standard technique is that in the standard technique, you go directly to the gastric varices, you can see here, and it didn't disappear compared to the the feeder vessel technique where you see the left gastric vein, you can see if there is any shunt, and at the same time you can decide, if you see a shunt, I didn't use glue, I just use more coils, and the results are immediately. You see the disappearance of the gastric varices immediately. You see, there's no addition. You see, so this is one of the big advantage. Also, we can detect sometimes, two feeder vessels. In this case, I see two feeder vessels by Doppler, and I make a treatment of both. In those cases, you need to treat the more distal part from the no distal part. So this is another case. So we can apply as a rescue therapy in this patient, for example. This patient received 5 treatment of glue in another hospital in another state and was sent to us. But when we were doing the US, we saw the embolia, pulmonary embolia due to the 5 treatment that she received. This as it was a 20 or 8 years old woman. So we went directly to the small area that I have, the chance you see the contrast, saw it and confirm it, and then I passed the coil, and you can see here the result after 28 days in intensive care unit. So as a take-home message, US guided therapeutic has increased during the last years with the development of new materials and techniques. It's a safe and secure approach that could obtain higher technical and clinical success. Experienced endoscopies in advanced therapeutic ERCP and US is necessary. The choice of approach may be selected based on patient anatomy. Thank you so much. I would like to invite you the last weekend of August to our live endoscopy course that is online. So 87 countries is for free. So please register with time. Thank you so much for your attention.